Hello, I'm Mark Mancini. I'm joined here with Wendy Hedrick. We're both of Little River Medical Center. Our CEO is Pam Davis. Wendy is our Chief Transformation and Innovation Officer, and I'm the Chief Innovation Officer. I'd like to remind you that there is a chat window open. If you have any questions during this presentation, you just type it in the window and we'll answer it when it comes up. Wendy?
Mark, thank you for the introduction. As Mark said, I'm the Chief Transformation and Innovation Officer here at Little River Medical Center, but my role also includes oversight of our telehealth program, and we're very excited at the opportunity to present to you today the great work that Little River Medical Center has been doing around telehealth. Just to give you a little bit of background of Little River Medical Center, Little River Medical Center has served the counties of Horry, Georgetown, and Southern Brunswick for over 40 years. Through its 6 locations. That includes the programs such as our medical services with family, peds, and geriatrics. We also have a dental program. We have 3 county Head Start programs that we service with dental services right now, but we are soon expanding that to include mobile medical services. Of course, we have our telehealth program working, and that also has a presence in our schools as we anticipate expanding that program as well. In addition to those programs, we also have a behavioral health, a Ryan White, and our migrant worker program. So I apologize, I missed all get into the first slide, but that lists us here what our services are. A few of those that I did not mention earlier were our diabetic educators, our TSWELL, which is our family planning services, women and children, and our homeless program. At this time, I will turn it over to Mark.
Thanks, Wendy. COVID hit everyone at different times. For us, March 12th was when we had an emergency meeting at our Carolina Forest location with LRMC management. This is the point where, for us, COVID had escalated and it was pivotal. We needed to discuss strategies and how we were going to handle the epidemic as a federally qualified healthcare center. One of the early things we did was to order tents and stanchions to handle the seeing of patients outside of our facility. We wanted to make sure that we had access to these before they sold out. As we know, there was a shortage of toilet paper because of the care and treatment of COVID required it, I guess. But our policies and procedures also had to be devised, updated, and implemented. We also implemented a work from home policy, which was new to us. Thankfully, being on a web-based EMR, that helped make things a lot easier. Our business operations took a radical change as fear started to set in. We had patients and staff now starting to come down with COVID. How were we going to handle that? So our worlds collided, and that's what happened on that day. And on the next slide, we'll go back in time. June 2018. More specifically, to my first Palmetto Care Connections Telehealth Conference, and that was back in April 2018. I was pretty new with Little River Medical Center, only being there a few months. I attended the Columbia meeting at the conference center, and it was there we looked at the different telehealth platforms. We had a grant opportunity for us provided by the USDA and MUSC. So as we looked at the different platforms and carts, we decided to standardize on the Iron Bow carts and utilize the CAPSA carts and the Polycom codec technology, as well as the Polycom Real Presence desktop to connect everything and deliver telehealth care. While I was there, I met with Matt Hyatt. He expressed interest in helping us and introduced us to the PSPN network and address book, and told us that we'd be able to utilize Polycom's Real Present desktop to connect everything. So thankfully, the grant we had with both the USDA and MUSC allowed us to procure about 18 carts for both medical and behavioral health usage. In 2019, 2 of the carts were deployed in schools, as seen here, unloading them from a U-Haul truck. And other carts that we had ordered were designed and set up for our sites, for our site-to-site usage. A couple of things I do want to mention. We did purchase a home unit, a portable home medic it's called, so we can use that for home visits. And we decided to standardize both our medical and behavioral health with one platform instead of two different manufacturers to try to lower our cost of overhead as well as lower our cost of support and understanding the technologies by having one consistent platform. We like the capsa carts because of the large wheels, able to go over door thresholds and so forth. And there's actually with the medical carts a web interface with Wi-Fi connectivity to help manage access to the draws. And that really sealed the deals for us with the capsa cart. And I have about a 15-year experience with VoIP technologies and utilizing both Cisco and Polycom. And that's what led me to more of a neutral codec with Polycom instead of Cisco, which does have some experience and background with trying to be not as neutral. The Iron Bow design, how they integrated everything into one head unit, was something that impressed me. The quality of the cart, the size of the screen, I thought for the price was a good bang for the buck. They also allowed us to use any software we wanted to use. We looked at some other carts that required usage of scheduling software, maybe forced usage of billing, etc., that we didn't want to be tied to. So that's the reason why we chose these carts, and we always get asked that question.
Although we had experience with telehealth through the use of our Iron Bow carts with the Polycom system technology for our school-based programs, that knowledge was limited and the program was still in its infancy when COVID hit us. So, here at Little River Medical Center, just like everyone else, we were, trying to work feverishly to continue to provide services. And some of these listed here are the platforms that we leveraged during that time. Our teams were quick to respond to not only learn themselves and how to expand the program, but also how to push out the policies and procedures to our staff and providers and training, as well as to our patients, because our patients are probably a key factor in the success of a telehealth visit. We do use phone visits as a last resort only because with our telehealth, when we developed our program, we wanted to make sure that it was a true audio-visual experience. And so the telephone visit itself is very limited and pretty much non-existent at this point, at least what we would consider a telehealth visit. Right now, we are using FaceTime and Google Duo as the restrictions around HIPAA have been alleviated a little bit, but we are using those as a secondary measure to Doxy.me and our Helo televisits through eClinicalWorks. The challenges that we faced are probably no different from what others had experienced. It was not only user-based, but also, as I mentioned, our patient base was not completely familiar with these technologies. And we found that while many of our patients might have email addresses, they probably didn't use them. And the ability to speak with your provider or support services through a telehealth visit was still new to a lot of folks. And so again, our challenges were just the same as everyone else's. Since COVID, over the past few months, we have narrowed down what our preferred methods are and what we are promoting to our patients. Doxy.me, which was provided to us at no cost through the PCC, thank you very much, has been a success. Our providers and our patients love the ease of access and the use of Doxy.me. We are still using the free version, so we haven't explored taking on additional features such as consent forms and collection of signatures. But again, we are using that. The other platform that we do use are our Helo televisits through eClinicalWorks. I'm sure if you've experienced Helo, it has come a long way from the time that it was rolled out at the beginning of COVID. It was very clunky in the beginning. It was very difficult for patients to access it, especially for those that didn't have email addresses and trying to educate our patients on how to even set up an email. But it has come a long way. We are looking forward to the next upgrade, which is going to allow us to pull in other parties into the visits as well. So kudos to ECW for making that happen. We do continue to use our Iron Bow cards, even though it's not up here. And as I'll speak to that in just a few moments. You know, our Iron Bow carts, like we said, were used initially for our school-based program. We did have some within the clinics, but they were not fully implemented and used on a regular basis. But we still continue to use those for our site-to-site telehealth visits. And so our telehealth right now provides audio-visual support for our medical, our dental visits. It also supports our behavioral health specialists, our diabetic educators, our EIS program, and again, like I said, our school-based program. So lots of great things happening with the telehealth, and we continue to figure out how we can improve upon those services. Right here, you'll see some pictures of our telehealth carts and our PUI tent areas that we have set up. PUI being our persons under investigation or COVID suspected patients. But you know, we try to structure our telehealth program in a way that facilitates the ease and access. You know, outside of our traditional direct patient home with use of Helo and our Doxy.me visits. As I mentioned, our site-to-site visits. With our site-to-site visits across our 6 locations, we've organized ourselves to where we have deployed carts at each of our locations. The providers don't necessarily need to be on site with the patient. If a patient presents themselves at one location, let's say in Myrtle Beach, but there is a provider available to see that patient who is now suspected of COVID, we can actually reach out to our provider that might be in Carolina Forest in the Conway area. I don't know, not everybody will know that, but anyway, not on site with the patient. We can go to that provider and say, hey, we're going to put this on your schedule so that you can connect with the patient at our other site. So that has been a huge, huge saver for us because, as you know, many of you are struggling with staff and provider resources as we are. The next thing that's listed here are curbside drive-up visits with those that are needing access to our labs and to our pharmacy. We have set up the ability for our patients to remain in their cars. We do use Helo and Doxy.me for those curbside visits. We also employ the iPads with FaceTime, especially for those patients who don't have data available on their phones, again, because we are trying to make we're trying to facilitate every telehealth visit as a true audio-visual experience with the provider. But in addition to the drive-up visits, that's really supported our nursing staff. And like I said, here with our labs, because our patients don't always necessarily have to come in, and a lot of them still have concerns over coming in. And so this was a great way, and we've gotten a lot of positive feedback from our patients as well as our staff and providers off being able to offer this. As I mentioned, our PUI areas, each of our locations has that. We are exploring other services through the use of our telehealth, such as a hybrid telehealth visit, and I can go more into that. But essentially what we are looking at is how can we incorporate a home visit component as an attempt to serve those that may not have the means to connect to a telehealth visit, or there may be other barriers to accessing care, such as a disability or transportation. And so that we're still under exploration of that, particularly with our pediatric population, since they are now they've got a lot of limited access for transportation, with parents being back at work and such. And I'm going to turn that over to Mark to continue.
And as Wendy made it sound so easy, with anything, we encounter barriers, things that prevented us from delivering the service at times that we had to deal with. Some of the barriers that we encountered, obvious. We set up Wi-Fi in our facilities inside our facilities. We never thought of a need to have Wi-Fi outside of them. until now. So we had Wi-Fi signals for our drive-up and POI tents that couldn't reach and get high quality. Initially, we drag a 100-foot Ethernet cable out for the POI tents, but that was just a short term. We needed to find better solutions, especially as we encompass more and more options with drive-up visits. The other thing is some of the technologies we had in our infrastructure. Believe it or not, we still had about 24 older 10100 Ethernet switches. They're being taxed with the extra bandwidth due to the audio video usage, which it was eating up a chunk of our available bandwidth as well as our internal infrastructure, and we started feeling it in other areas. Having 6 sites and with the technology, as Wendy had said, the eClinicalWorks was making changes to the Hilo telehealth visits on a regular basis. How do we get that information? How do we communicate the information to all of our staff at 6 locations effectively? Because without that, they would be stressed. Maybe a window would change, the look would change, and how would they respond to it? So it was a constant training to our staff that we had to deal with. There was the concern, even though we were told, will the payers will reimburse us for telehealth visits. Will that really happen? As an FQHC, we weren't able to get telehealth funds, reimbursed. And they told us we would. So there was those questions as well, investing the time, resources, and energy to a visit we're hoping we can get paid for. And then we had to deal with patient technology and the limitations of their phones, their knowledge, downloading apps, clicking on links, enabling audio, all the things needed for a telehealth visit that involved a lot of technical support. So our nurses and MAs became technical support people. Again, these were things that we didn't anticipate, we weren't ready for, but no one was ready for this epidemic when it hit. Luckily, though, we were able to break through those barriers. And so on the next slide, we'll talk about the resolution to some of these barriers. The wireless access points, how we dealt with that. The wireless access points, and I've been told I should not use the acronym for them anymore, were mounted outside the building, pointed towards the parking lot where our tents were and our drive-up visits were to be, and connected it to our secure corporate infrastructure and provided fast, reliable internet without having to run wires out there. And that solved the problem for connectivity, at least. Then we had a bigger issue. We had a large project where, like I said, about 24 10100 programmable switches with VLANs had to be replaced with gigabit switches. And in the past, these switches were connected via daisy chain using Ethernet cables, which isn't exactly the best way to have a large campus-wide connectivity infrastructure. So we replaced them. We had HCC go ahead and rebuild literally our setup with fiber concentrators and copper uplinks, instead of copper uplinks, I should say, so that everything was literally gutted and replaced and designed not only for our current needs, but any future growth with audio, video, and telehealth. That switching upgrade definitely helped alleviate some of the constraints and bottlenecks on our network. And it helped us too with using Teams, Microsoft Teams with Office 365 to help train our staff, go out there and provide web meetings and so forth during lunch hours to explain the differences with each update with Hilo and Doxy.me. The enhancements that both eClinicalWorks and Doxy.me definitely made it easier for us to see the patients more and more. Initially, I believe eClinicalWorks required the patient have a web portal account and log in through that. And that was a lot more cumbersome. Not everyone wanted to provide an email address. But then they started doing it through an SMS link, which made the connectivity easier, removed a lot more barriers. I will say Doxy.me definitely helped simplify the process for many of our patients. It was an easier setup, and definitely thank them for that and Palmetto Care Connections for assisting us with that. Finally, probably the most important thing is we let out a large sigh when we found out we actually were getting reimbursed from the payers for telehealth visits. And also, too, Wendy and some others had some great ideas with the walk-up visits and drive-up visits. When a patient is seen on our premises, even though they're seeing telehealth, they can be billed for a full face-to-face visit, not a telehealth visit. And that allowed for full reimbursement. So we didn't have to worry about reduced pay as you would with a direct-to-home patient visit. So it definitely helped us economically sustain ourselves and our staff through this tough time. And Wendy, you can tell them about our Telehealth Future.
Thank you, Mark. So while our presentation has been focused around the delivery of a face-to-face visit between the patient and the provider, one of the other components of telehealth or telemedicine as a whole is our remote patient monitoring efforts that we are also working with, and we are trying to access grant funds to help support things such as at-home monitoring services, whether it's a blood pressure monitoring, scales. Part with our pediatric program is looking at how can we help support our patients with the childhood obesity. Looking at ways to maybe help remotely address things such as fitness goals and things like that. And so I don't want to leave that in the lurch, because I think that is an important piece of telemedicine when we talk about delivering a holistic approach of care to our patients. We have solicited our patients' feedback through our practices surveys. And we had, out of 288 patients that responded about using telehealth, again, 70% said that they would very likely use those services. And so, Mark and his team and I and my team are, working hard to, solicit for everyone's feedback within the organization to figure out how can we work to improve that so we can continue to provide the services that are needed, but also be able to provide them where it is financially feasible. We do understand that there may be changes in our future to that reimbursement methodology. But with Little River Medical Center, we have fully embraced telehealth as part of our mission to serve our South Carolina population. You see North Carolina mentioned here because we are on the border of North Carolina. But we have got a lot of great things, a lot of great ideas going around right now. We are talking about telehealth visits for family planning, specifically for a contraceptive. And so we're actively having discussions with the group about providing those services. And just to put it in perspective, from January through August, we had 6,600 telehealth visits facilitated in one of the different ways that I had mentioned earlier in our program. So we've got a volume there. We believe that we can continue to build that volume based on the feedback that we get from our patients. And I think if we work to continue to improve those services, that we could exceed or at least reach that goal again for next year. As Mark said, we do have a portable medic. We have put in requests for additional grant funding to cover purchase of more of those to help support not only what we utilize in our clinics, but also with things such as our hybrid telehealth visit that I mentioned earlier. We are also acquiring more iron bow carts to help facilitate those services site to site. And as mentioned here too, iPads are a big staple of ours in our practices because they are portable, and with Mark's great team to be able to expand our Wi-Fi connectivity in the parking lots. Patients don't have to worry if they have the ability to connect to their providers because we have those iPads that we can at least help facilitate those visits.
Thanks, Wendy. Well, we're learning a lot in the last several months. And I do have to say thank you thank you to Lather and Woodard from the South Carolina Primary Healthcare Association. Absolutely love her quote she keeps reminding us of every time we see her. Blessed be the flexible, for they shall bend and not break. I also want to let everyone know that healthcare changes fast, as we've seen in the last couple of months. How we practice medicine and how we will practice medicine in the future is going to change radically. And I remember that first telehealth conference there in Columbia, Dr. Chris Gibbons gave a great speech. And if you can go back and watch that video again, he was spot on so many things. And definitely want to thank him for some of the inspiration that he gave us. In our future, and what we learned is that, we're constantly evolving, and telehealth is constantly evolving. We are not only looking forward to providing more telehealth, but advancing with, as Wendy said, the RPM care, remote patient monitoring, and try to expand and provide some more proactive care to our patients. And that's our goal. We want to monitor them 24/7 and have it integrate with our EMR. And I'd like to leave with something that I know has inspired many of us. Kevin Brown posted this: are you using COVID as an excuse or as a catalyst to get better? And reminds us that we need to kind of prepare in the good times for the lean times. And hopefully many of us learned that lesson from this. 2020 has been a hectic year, but we're going to get through this, and 2021 is going to look even better. So with that, if you haven't asked any questions yet, now is the time. Wendy and I are here to answer any and all of your questions. Thank you.